Medication Errors by Brittany, Kelly, Lacey, and Brittany. What is the research question? In nursing, how does using a no distraction sign compared to no sign affect rates of medication errors after 30 days? What is a medication error? We pulled from two sources who had very good explanations of what it is. The first one is the administration of medication that did not meet the standards of the five rights, which are the right patient, right drug, right route, and right time. The second one we have is only 656 medications were available in 1961. Now over 8,000 are being prescribed, with more than 17,000 trade and generic names in North America alone. Why do we need change? Medication errors have many negative effects, including death. In 2016, there were 1,165,073 new reports of adverse medication events. 110,179 cases required hospitalization. For 2016, the annual toll included 45,255, 14.5% patient deaths, and 110,179 cases, 35.3%, requiring hospitalization. Total national costs, lost income, lost household production, disability, and healthcare costs of preventable adverse events, medical errors resulting in injury, are estimated to be between $17 billion and $29 billion, of which healthcare costs represent over one half. So we've identified that we needed change, but what exactly needs to change? Medication errors need to be decreased in order to increase patient safety. Decreasing interruptions allows nurses to adhere to the five rights, increasing patient safety. Decreasing interruptions during medication administration decreases errors. According to Jones, 2009, 59.3% of errors occurred during the administration stage. Joint Commission lists medication errors as the ninth most common sentinel event of 2016. Here is some background information to further explain what a medication error is and how important it is for us to decrease the amount of medication errors today. Wolak said, a distraction is defined as anything that draws or diverts attention from achieving the originally intended goal. Anthony said, medication administration took up to 17% of the nurse's time, and each nurse averaged 30 interruptions per shift. Distractions have been found to be the second leading cause of medication errors. Distractions allow nurses to deviate from the five rights. Not checking the patient's ID and allergy bans is the most common violation. Some proposed changes we've came up with was to find out how to decrease medication errors by decreasing interruptions during medication administration, also increasing the patient satisfaction, which is one of the most important, and decreasing medication errors in order to decrease hospital stays, including associated costs, patient disability, and death. What is the purpose of our study, or what is the purpose of all the studies that we've listed below? The purpose of this study is to ascertain if a do not disturb sign will decrease interruptions during a medication pass, therefore reducing medication errors. Some sources of interruptions that nurses may have are another nurse, patients, technical sources or problems, operational failure, unavailability of medications, or infusion device required for medication administration. How would we know if the study was beneficial? What outcomes would we look for? Well, first we would look for a decrease in medication errors. Also, decrease in incident reports, increase in patient satisfaction, medication errors decreasing hospital stays, costs, patient disability, and death, and decrease in adverse events. What would be measured in this study? How would we find out the outcome? We would look at the medication error reports from the hospital's EMR, or the electronic administration system that the hospitals use, or we could look at the incident reports that are kept on file within the hospital, just like the picture to the right showing the incident report form.
The first research study used headphones to decrease distractions at a medication access station. Conclusion was analysis demonstrated visibly distracted states decreased 61% with use of headphones. The difference was statistically significant. The headset did intentionally cause distractions and did visibly distract states were decreased. Some of the limitations to the study were 28% rate of surveys had a low response rate. There was no randomization, observational study, RNs may have changed their behavior due to being observed. No statistical analysis of inter-reader reliability was performed. Further research said that additional ways to reduce environmental stimuli and evaluate nurses' perceptions or distractions. The second research study was a literature review. The purpose of the study highlighted factors that contributed to medication errors, including the safety culture of institutions. It also discusses factors that relate specifically to nurses, such as patient acuity and nursing workload, the distractions and interruptions that can occur during medication administration, the complexity of some medication calculations and administration of methods, and the failure of nurses to adhere to policies or guidelines. Conclusions for the study: risks contributing to medication errors were classified into three categories: patient, system, and personal factors. Interruptions were the main factor contributing to medication errors. Some interruptions are acceptable and unavoidable. For example, a patient alarm or patient whose condition is deteriorating. Failure to check patient ID bands and allergy bands were found to be the most common medication error. This was done to save time. Lengths of shifts, night shifts, total number of hours worked, and high workloads result in fatigue, which leads to medication errors as well. Possible areas of further study concluded interruption-free zones, do not disturb vests, armbands, or signs, specific times during shift for medication passes without clear interruptions. Research study number 3. The no interruption zone is designed after the sterile cockpit rule. From aviation, no necessary tasks or conversations below 10,000 feet. Red tape was put around medication carts and central dispensing area. Before the no interruption zone was implemented, the percentage of interruptions were 31.8%, and after the no interruption zone was implemented, the percentage was 18.8%, a 40.9% decrease. The limitations of the study were that the study was conducted in 2 ICUs, limiting the generalization. Observation was used to collect the data for a 1-week period only. Further research concluded that the no interruption zone was effective on the ICU. Additional studies with other units need to be conducted for further research. Research study number 4 examined the evidence relating to the causes of medication administration errors and methods to reduce such errors. Further research used checklists to increase compliance of protocol and to examine use of science to decrease distractions. Research study number 5 is more than 10 years old but pertinent to our research. 2 different do not disturb signs were used to determine if they decreased medication errors. Self-reported survey was used for nurses to rate the degree of severity of distractions that occurred. Conclusions. Greatest reduction was from distractions from other nurses, 5.60 to 2.90 mean score. Physicians did not abide by the signs. There was very little reduction in distractions. Nurses have to check patient ID and allergy bands each time they pass medications. Nurses have to educate patients about medications, including the dosage. Greatest distractions were from other nurses and personal conversations and loud noises. Another important advantage of reducing distractions was in allowing nurses to complete medication delivery more quickly and get on with other patient care's needs.
The benefits and risk of our study is that the cost of doing nothing versus the cost of improvement. Annual toll is 45,255 patient deaths. Annual cost is between 17 and 29 billion. The cost of improvement is minimal. Staff education and cost of science. A benefit would that it would decrease medication errors, which increase patient safety. Our design plan will consist of a proposed change to decrease distractions in order to increase and higher to the 5 rates of medications in order to decrease medication errors. A do not disturb sign on medication cards would be put during administrations of medications. A quasi-experimental design would be used to determine if the Use of signs decreased medication errors and increased to the 5 rates. Data would be obtained by electronic medication record from the nurse's managers or pharmacy. The same group of nurses would be used to measure the numbers of errors before and after the do not disturb sign. A convenient sample would be used. RNs and respiratory therapists would be used because they are available on the unit and are the ones that pull the medications. The setting in this research study would take place in an urban hospital since hospitals have the large amount of medications to pass. Most hospitals already have EMR systems which have been proven to reduce medication errors and are needed for data collection. Implement patients one unit at a time. The participants used for this study would be RNs working on the unit and respiratory therapists working on the unit. Inclusion criteria would be anyone who completes a med pass while using the sign. Exclusion criteria would be anyone who does not use the sign or does not sign a consent. The rule of 30 would be used for the sample size. The rule of 30 means there should be 30 subjects for each group or 30 subjects for each variable. The sample size would be around 60 to 70 participants, which would meet the rule of 30. Resources needed for the study would be signs, tapes, someone to collect the data from the EMR, collection data from incident reports, and statistics software to analyze the data.
Implementation process. In-service learning to educate RNs and RTs about new plan to reduce distractions and therefore errors. Hospital, implement one area at a time. Pilot study. Nurses feedback if changes are needed. Put signs up in med rooms and at nurses' stations with information. Observe for a reduction in med errors. Tool for measuring outcomes, which is the EMR report. Have super users available for questions. Need to make a standard operating procedure guidelines and policies readily available and one unit at a time.
The data collection used for this study would be measuring the number of med errors from an EMR, measuring the number of incident reports filed, number of errors in each category, the right time, the right dose, right patient, right drug, and right route. Statistics would be obtained from the nurse manager or pharmacy. A quasi-experimental design would be used. A quasi-experimental design definition is an experiment research design in which individuals are not randomly assigned to a group, but rather than the research manipulates the independent variable and implements specific control to augment the internal validability of the outcome. This is the spreadsheet used for a research study. We would measure the medication errors before the study, during the study, and after the study.
Setting to implement. Our setting was a hospital and we used one unit at a time. Most already had the EMR system, which reduced medication errors, which would be a variable in the study. Hospitals have large amounts of medications to pass, which would give a large sample size. In-service education about no distraction signs and the purpose of the signs.
How would we implement this study? It would depend on the nurses working on the unit. The inclusion would be when the nurses complete a med pass with a no distraction sign. The exclusion would be does not use the distraction sign or on their wheelie or does not sign consent. We would inform the nurses of this study and get a signed consent for them to participate and get a consent from the hospital review board.
Who would be interested in the change? Stakeholders. Decreasing medication errors, increase patient satisfaction and hospital ratings, and increase chances of accreditation. Insurance companies will be interested. It decreases costs and patient disabilities. Medication errors increase costs from $2,262 to $4,685. Patients, because it increases patient satisfaction and decreases risk. Communicate to stakeholders by email and posted notices.
How we would monitor the outcomes is that we would meet with the nursing staff and respiratory therapists in a pilot study to review the revisions. We would determine if the study meets evidence-based practice protocols and standards, and if so, we would implement into other units. Communication information to administrators and collaborating medical staff. We would in-service education for all nursing staff and respiratory therapists. We would do ongoing monitoring of outcomes on all units. We would monitor rates of medication errors and monitor rates of incident reports.
The end. Say no to distractions.